Thanks for coming today. Today we're going to talk about behavior therapy for children and adults with Tourette's. Actually, we're just going to focus on children primarily because this is Division 53. What I say for children is pretty much true for adults too, so you can extend it upward for a change instead of extending downward. Well, what I'd like to do today for the workshop is to do a lecture on Tourette's, basically tell you a little bit about the disorder, describe the behavioral model for the disorder, explain why we would use behavior therapy for a condition that is clearly neurological in basis. And we'll then describe the treatment based on that model and then provide evidence supporting the utility of that treatment. At that point, then we're going to review the protocol, talk about what we do step by step in the treatment, and then we'll take some time to practice the core skills of the treatment components. And then if we have time, we'll do case discussion, demonstration primarily because of the filming. And then if we have time to talk about individual cases, if anybody has cases to discuss, we can do that. So let's start by simple definition. What is a tic? What do we mean by that? We don't mean the bug that you find in the upper north woods. We mean a sudden, rapid, recurrent, non-rhythmic, stereotyped motor movement or vocalization. All right? These are bits of movement or sounds that people make that are essentially seen as uncontrollable, viewed as uncontrollable. The syndrome, and I would like to credit whoever came up with this. Somebody sent it to me and didn't tell me where they got it from, and I've looked and I haven't been able to find it. But I think this is a great slide because this is the man who discovered Tourette syndrome, Gilles la Tourette. He was a French neurologist who worked with Charcot. And being a neurologist, he viewed this malady of tics, as he called it, as a very biological disorder. He viewed it as having a root cause in disrupted biology. The way he discovered the syndrome, he didn't call it Tourette syndrome, by the way, that would be a little vain. He called it a malady of tics. But the way he discovered this was, Charcot, being the famous neurologist that he was, would get case descriptions from all over the world of these people with weird neurological or movement symptoms. And he would, when he, as a big professor in his field would do, he had people working for him and he would divvy up the work. And he divided some of this work when he started getting these case descriptions to Tourette. And he said, why don't you look at these case descriptions? They all seem to be the same. They shout out words. They make these kind of jerky movements out of nowhere. Why don't you look at this and see if there's some commonality there? And as he was reading the case descriptions, he realized that really these people in Nova Scotia, these people in South America, these people in Russia that he was reading about were really kind of all the same. And he called it a malady of tics. And I think he wrote his original paper in, 1885. And then he died a few years later of syphilis complications. So that was the end of Tourette. And as Tourette died, his biological interpretation of the disorder, you can think of, sort of died with him. He viewed this syndrome as a biological illness, and when he went away, it sort of went underground. Nobody paid much attention to it in the medical community for a while until psychoanalysis picked it up again in the early 1900s. And you can imagine if you're an analyst, you would have a field day with interpreting some of the symptoms that go along with Tourette's. And when the analysts started to pick it up again, it really started to get viewed as a psychological disorder, a disorder of dysfunctional psychiatric origin. And that approach to understanding Tourette syndrome really kind of stuck around until about the 1960s or 1970s when antipsychotic medications were found to be effective in treating Tourette's. At that point, the disorder again became much more biologically interpreted. It became understood again as a biological disorder. So the disorder has actually had sort of a long history, and it's fluctuated in how the medical profession has viewed the role of the environment versus the role of biology in creating the syndrome. You can see Tourette is actually exhibiting a few tics for us. I don't have any sound on this, but he's exhibiting our motor tics, and every tic he's exhibiting is a simple tic. A simple tic is a very discrete, sudden movement, or sound, actually. A complex tic is a much more purposeful-looking type of movement. There are two. When we talk about simple versus complex tics, we also categorize them as motor versus vocal. Sometimes people call it phonic. The distinction between motor tics and vocal tics is obvious when we talk about topography. In other words, motor tics or movements, vocal tics or sounds. But to be honest with you, there probably isn't much difference between the two of them, because you can't make sounds unless you use muscles, unless you move, because that's what speech is, for example. That's what sound is. It's movement of muscles in your throat. So really the distinction is probably a little bit arbitrary. In any case, we have 4 classifications: simple motor tics, simple vocal tics, complex motor tics, and complex vocal tics. Simple motor tics are these discrete one-off movements like eye blinking, shoulder shrugging, neck movements, those kinds of things. Facial grimacing, mouth stretching, those kinds of things are very common motor tics. Simple vocal tics are very quick sounds that people make. These are usually confused with coughing, like somebody has coughing, or an allergy, sniffing, those kinds of things. So even small animal noises, those kinds of things can all be tics that people will have that are very discrete, very simple. The complex motor tics are either sequences of simple tics that people have, or, for example, somebody who in the same pattern all the time goes like this. That would be a complex motor tic, even though it's made up of a series of simple motor tics. Another complex motor tic would be something that looks more purposeful. And this actually creates a lot of diagnostic confusion, because a lot of people see these and they think they're dealing with OCD. They're not, but they think they're dealing with OCD. So complex tic. Okay. In certain circumstances. In certain circumstances, that's very much OCD. But you know, you can't define on topography, you've got to define on function, and we'll talk about that perhaps later. And so complex motor tics are those kinds of things. Sometimes you'll see touching, tapping, evening up, squatting, turning circles when you're running. I mean, it could be any kind of thing. Playing air guitar, I heard somebody doing that yesterday. That was a tic that they had. So I mean, there are all kinds of, any movement you can make can be a tic. Complex vocal tics are words or phrases that people say. The most commonly thought of vocal tic is swearing, and that's a symptom called coprolalia, which is saying the obscene words or bad words or inappropriate phrases, you know, those kinds of things, insults to people, racial insults, whatever. That's actually a very rare symptom of the disorder. A lot of people think that that's the defining feature of Tourette's, and it's actually not. It happens in about 10 to 15% of people with Tourette syndrome. So it's a very uncommon symptom. And a lot of times when people do have this, they actually mask it. They don't actually say the word. So if the F word is your tic, it won't come out as the full word. A lot of times it'll come out as because they know it's coming, and they try to stop it, mask it, make it change somehow. But in their mind, what their intention originally is to have the F word come out. Tics are involuntary, and that throughout the rest of this talk, it's going to be important to understand that. Against the backdrop of everything else I say, understand that tics are involuntary, and we'll have to explore what that word means here. That's actually one of the tough things about Tourette syndrome is where does voluntary and involuntary actually meet? And it meets right here, I think. The tics are involuntary, although they can be suppressed. Now that's the interesting part. Unlike almost every other movement disorder, which this is classified as a movement disorder in the neurology field, unlike almost every other movement disorder, Tourette's can be suppressed. Parkinson's, you can't suppress your tremors. You can do other things that make your tremors stop temporarily, but you can't stop your tremors intentionally. In Tourette's, you actually can. Another interesting feature that I think will be important in understanding Tourette's, and tics in general, this isn't just Tourette's, is that there's an experience right before a person tic in most people called a premonitory urge. Now, a premonitory urge is a feeling, it's a sensory experience people have right before they do the movement. Now, the urge is experienced as either occurring in the area of the body in which the tic occurs. So, for example, if it's a neck-jerking tic, the feeling might be in the neck. Or it could be experienced as more of a broad sensory discomfort that is building up right before the tic happens. When the tic occurs, that discomfort is relieved. So if you really want to kind of get a feel for what this might look like or what this might feel like and what I'm talking about, think of it like this. I've heard it described as that feeling right before you sneeze. You know, that kind of tension, whatever you call that, and we don't have good words for that, by the way. I've heard it described as that. And then I had a kid once say, you know what it feels like? He said, do this for me. And he said, open your eyes really wide, and go ahead and do this, and you'll get a feel what it's like. And then don't blink. Just kind of keep them open and stretched as much as you can without blinking. And then notice what you start to feel around your eyes. You should start to feel this sort of, I don't know what you call it, pressure, tension, and then let go. And you'll find yourself kind of going like that and maybe rubbing your eyes a little bit to get rid of the feeling. That feeling is called a premonitory urge. That's what they experience right before they do the movement, except that feeling happens anywhere, right in their body. Now, it's interesting because the premonitory urge, when you ask adults, do you have a feeling or do you know when your tics are coming? Can you tell? Is there discomfort? About 97, some studies suggest 97% of adults at least will tell you, yes, I know when they're coming. I can feel it. I can feel this urge. When you get to kids below the age of 10, maybe about 30 or 40% report it. Now, the question is, does that mean kids below the age of 10 don't have these things? Or is it something else? The way it's written in the literature, a lot of what you hear is that kids under the age of 10 don't have premonitory urges to their tics. They develop later. I'm not so sure that's true. We've done studies looking at kids under the age of 10 and how they describe these experiences, and kids over the age of 10 and how they describe these experiences. And the measures we use to assess these actually show that their levels of premonitory urges or these pre-tic sensory experiences are equal before treatment and after treatment. The difference is in how they describe it. Children under the age of 10 don't have a concrete set of words. They don't have language to describe these internal experiences the way older people do. And so really what I think is happening is children under the age of 10 have these sensory phenomenological experiences, but they don't have the words to describe it. As they get older, as they get better about talking about internal experiences, that language shows up. Now, how do we know this clinically? Well, we know it clinically because as part of our treatment, we try to teach people to be aware of their urges, to let us know what when this experience shows up. So we'll play a catch the tic game, for example, where we'll say, okay, now, you and I are going to sit here, we're going to catch your tic. The first one to catch the tic raises the finger, and then they win, all right? So we'll go back and forth, and the child will do the tic. The 8-year-old will do the tic. And he'll do his head, and I'll say, right there it is, and I'll get my finger up first. And I'll say, I won, let's do it again. He does another tic. I raise my finger right away. And I say, I win again. The next time he does it, I wait a little bit and he catches it. I'm like, oh, you won. And we keep doing this over and over again. And if you do it long enough, what you'll find pretty soon is that the kid goes like this. And I'll say, wait a minute, you're cheating. How'd you do that? And the kid gets very defensive. What do you mean I'm cheating? Well, you put your finger up before you did the tic. Now, how could you possibly have known that? How did that happen? And the child said, well, I don't know. I just knew it was coming. Okay, how'd you know? I don't know. I felt it in my neck. Okay, what are we going to call that? And then we give it language, and then we start describing it. It makes it concrete, and then we can start talking about this premonitory urge with the child. It's not that it wasn't there. It was there. The kid just didn't have the description for it. So we can give them the description. Okay. I realize I didn't put this in here, but the definition of Tourette's. Let's talk about that. Tourette's, by definition, is 2 motor tics and a vocal tic that have been present for more than a year with no tic-free periods of more than 3 months. There are other tic disorder diagnoses. There is chronic tic disorder, which is motor or vocal tics, but not both, for more than 12 months. There's transient tic disorder as well, which is motor and or vocal tics that have been present for more than 4 weeks, but less than a year. These diagnostic differentiations, in a lot of ways, are meaningless, okay, with one caveat. you have to understand that Tourette's is actually, not Tourette's, but tics themselves are very common. They're a very common part of motor development. So 25% at some estimates suggest that kids will have tics as they develop motorically. That's just a very common feature of motor development. It's usually very transient. It's 2-3 weeks. You'll see an eye blinking thing when they're 3 or 4 years old and it goes away. That's common. But once you get after tics happening a couple months, then you're probably dealing with something a little more chronic. The distinction between chronic tic disorder and Tourette's probably isn't very meaningful, to be quite honest with you. And patients, they'll often come to me and they'll say, "Oh, my doctor said I have a tic disorder," and I'll say, "Well, what do you have?" "Well, I've had these 3 or 4 motor tics and these couple vocal tics for about 5 years." Like, yeah, you have Tourette syndrome, and that very much scares them. "Oh, I don't want Tourette syndrome. I just want a tic disorder." And it's like, well, really, there isn't any difference. And here's how I'll explain it. If you have 5 motor tics and 3 vocal tics for 364 days, you know what you have? You have transient tic disorder. Now, that sounds beautiful and benign. On the 365th day, you get Tourette syndrome. Okay, that's how arbitrary this distinction is. So in a lot of ways, we can't get too hung up on these labels. Don't think that Tourette's means anything worse than chronic tic disorder or transient tic disorder in a lot of ways. Where people usually get confused is when people say Tourette's, they usually mean tics plus a whole host of other comorbid conditions. And that's not accurate. I'm a splitter, I'm not a lumper. So, to me, tics are the Tourette's, and then a lot of times Tourette's has other comorbid conditions. All right. Prevalence of Tourette's. Well, let's start with the prevalence of transient tic disorder. Some people think 17 to 18% of children will have transient tic disorder at some time in their life. Okay, that's probably a high estimate, but that's what some have suggested. Chronic tic disorder, probably about 1 to 3% will develop a chronic tic at some point in their life. Tourette syndrome, the DSM says is 0.04 to 0.05%. I think that's a pretty gross underestimate. I'm guessing it's probably about 0.5 to 0.6% when you include mild cases. So it's more common, I think, than people think. The disorder starts in young children, typically starts between the ages of 4 and 6. It's much more common in males by ratio of 4 or 5 to 1. It starts usually with motor tics, then vocal tics. The most common tic to start with is eye blinking. That's actually usually the first sign that something's happening. But that's also one of the most common transient tics to develop too. Tics develop in a head-down direction, so they'll start mostly in the face and in the head. Almost everybody with Tourette's has some sort of head or facial tic, and then the tics progress down the body as the child develops. About 60% of kids with Tourette's have tics below the waist. Almost all of them have tics, in the head and above the neck. Simple tics usually start first. Occasionally, I'll get a case where the child comes in with a very complex tic, no history of simple tics. That's probably not Tourette syndrome. That's probably something else. It could be Sydenham's, it could be OCD, it could be a host of other things, but it's probably not Tourette's if it starts with a complex tic. It could be something, at least potentially, that people are calling pandas, which you probably have heard of, and we can talk about that later if you need to. But it usually starts with simple tics and then complex tics. Now, Tourette's, the way the disorder works, it starts between the ages of 4 and 6. It starts to escalate and peaks in severity somewhere around the age of 10 to 13, right? Which is cruel because that's about the time the child's entering junior high, which is when children also get their nastiest socially and start to really go after each other. But that's the way the disorder works. It seems to exacerbate around puberty onset. For about a third of the children with Tourette's, their tics, as they grow into adulthood, will start to diminish and even disappear. In a third, you can think of it as they'll recover by the time they're 20, let's say. Another third will have tics, but they'll be much lower, they'll be much less pronounced. And by the time they're 18, 19, 20, they'll have tics, but they'll be very subtle, and most people may not even know that they have them. Another third will maintain into adulthood and even worsen. So think of the rule of thirds, roughly. Unfortunately, we don't have good predictors of who will do what. Another key piece of understanding Tourette's is that the symptoms wax and wane, and in a lot of different ways. So just from the overall severity of the disorder will be increasing for a while, it might be really high, and then it'll start to diminish to the point where the symptoms aren't even there anymore. It looks like they're completely gone, except maybe a little bit of one tic, and then they'll flare up again. So there's that overall level of waxing and waning. There's also a symptom by symptom waxing and waning, so that some symptoms that have been around for years will suddenly disappear and a new one will emerge. So new tics start, old tics go away. That's a very common feature of the disorder as well, which makes it actually tough to study in a lot of ways because the disorder is a little slippery. You have to use different types of methodology sometimes to really capture what we're looking at. In Tourette's, comorbidity is the norm. It's not the exception. Most kids with Tourette's, a large percentage, will have at least one other diagnosis. The most common in the literature that's described is ADHD. Some estimates suggest that 50 to 90% of kids with Tourette's have ADHD. Personally, I think that's a very gross overestimate, especially the 90%. I think it might be 50 to 60% at the top end. The reason I say that I think it's probably an overestimate is if you look at how a lot of these studies on comorbidity have been done, they've been done in sort of Tourette specialty clinics that the sickest of the sick go to these clinics. And when, obviously the sickest of the sick who are coming are going to have other problems as well. And that's where a lot of these comorbidity data have started to be generated from. So I think when you look at a broader community sample, a more open sample of folks, you might get a different picture. I think ADHD is still probably the most common comorbidity. I just don't think it's at 50 or 60% when you look at the general Tourette's population. I think that might be the high end. Comorbid conditions in general will onset after the tics, with the exception of ADHD. Usually something's happening in terms of the attention and the hyperactivity before the tics actually onset. That's usually noticeable to the parents before the tics themselves will start up. But the other common comorbid conditions with Tourette's, like OCD, and some people think up to 50 to 70% of people with Tourette's will have OCD. Again, I think that's an overestimate. Partially because of the sampling bias and partially because I think people are misdiagnosing complex tics as obsessive-compulsive disorder. But the comorbid conditions like OCD come later. Reading disabilities, math disabilities are common learning disorders that happen in people with Tourette's. It's not clear if that's due to some organic substrate that's leading to those dysfunctions or if it's the tics themselves that are just impairing learning, which could be. If you think about a person with a vocal tic who can't focus on a page for more than a second, reading will get difficult, for example. Depression doesn't seem to be elevated any higher than the general population in Tourette's, as far as we can tell. And we'll talk about anxiety a little bit later as a comorbid condition. The typical course of treatment for Tourette's, the most common intervention is nothing. Be quite honest with you. Probably the best first-line intervention is telling parents to back off and don't worry about it and just see what happens. Because there's a good chance that the tics will fade away on their own. If the child is experiencing no functional impairment, if the child is experiencing no social impairment, if things are fine, the child has friends, doing well in school, so on and so forth, and the tics aren't interfering, we don't treat. Even if they're very noticeable, we wouldn't necessarily treat. It's only when the impairment starts to start up that's when intervention is usually warranted. At this point, the most common intervention, if we actually have to intervene, is medication. The options aren't great, frankly. The most common medications people start with are things like guanfacine and clonidine. Okay, those two medications are used. They do all right in reducing tics, but they're used primarily because they have a less negative side effect profile. And those two medications also have some added benefit in that they help attentional symptoms, attention deficit symptoms in people with Tourette's. And since that's such a common comorbidity, those medications are typically what the psychiatrist and neurologist will start people on. If they don't respond to those two types of medication, those two medications. The next step up are atypical antipsychotics. Risperdal is a big one. It's probably the one that people use most often. If the atypicals don't work, then they move up to traditional antipsychotics. Geodone or Haldol are the two big ones. Haldol's just an awful drug in terms of side effects and so on, haloperidol. But it does do a good job in terms of reducing tic severity. It does a good job of reducing pretty much everything, and I think that's probably why it works. It shuts down a lot of behavior. Side effects for the atypicals and the traditional antipsychotics are great: cognitive dulling, fatigue, weight gain, so on and so forth, blurred vision, those kinds of things. So a lot of people drop out. Some studies of Haldol for Tourette's populations suggest 80% dropout rates of the treatment. So people don't stay in treatment for Haldol. And at this point, most children with Tourette's don't receive Haldol anymore. Parents don't want to go to that. If the medications don't work, then there are other options. The two other options that are probably most common I'm talking medication intervention. The two most common medical interventions past drugs themselves are deep brain stimulation and Botox injections. Okay, so Botox injections are injections of botulinum toxin right into the muscle where the tic is happening. It works fairly well because it paralyzes the muscle, so they don't tic very much. Now I've heard conflicting reports. I've heard some people on Botox say, yeah, I didn't tic anymore, but the urge never went away, and it drove me completely insane. So it's like feeling like you have to sneeze, but never being able to sneeze. And so I've heard that happens. But I've also heard conflicting reports that the Botox actually reduces the urge to move as well. So that's, we don't know where we're at with that. In children, there have been no controlled studies on Botox use. So, we wouldn't say that that's empirically validated for use with kids. Deep brain stimulation is another treatment that's really come on. Deep brain stimulation is actually used quite frequently in Parkinson's disease now, in later stage Parkinson's disease. It's used in treatment of dystonia. So there are lots of different things that deep brain stimulation actually has some good evidence for, starting to be used in OCD and depression and so on and so forth. Essentially what deep brain stimulation is a surgeon will come in and they'll put holes in your skull and they'll put long metal wires, they'll gently put them down into your brain, and they'll target a particular area of your brain. In this case, it's the basal ganglia for Tourette's. And then they'll run a wire under your scalp, through your skin, and implant a little box. Think of it as a pacemaker for your brain. And they'll put the box under your skin right here, and then they have a device that they can program the stimulator through your skin to deliver a specific level of electrical stimulation into your brain. And they'll adjust the stimulation to see, kind of like how you're moving and when you're stopping and how high it has to get before the tics slow down. Now, the evidence for this in kids isn't great, but in adults, it's starting to, there's some moderate evidence that it could be effective, and it's really starting to heat up for the cases that are sort of uncurable or not helped by other treatments. The problems with deep brain stimulation, there aren't really good controlled trials in kids, so that's a big problem. B, we don't have any clue about the long-term effects of deep brain stimulation on other functions. So, one can assume that running two metal wires into your brain and then running electricity through it might have some kind of negative effect, but we don't know for sure. Essentially, your brain is full of current anyway, so maybe it's not. And if, maybe if the wires are clean, I guess you're okay. I don't know. But we don't know about the long-term effects of the deep brain stimulation. The problem that we've heard coming up in Tourette's, I don't know how widespread this is, but kids with Tourette's tend to be very sensitive in terms of sensory experiences. They tend to be very kind of like hyper-aware of sensory experiences. And what we've started to hear are reports of people like feeling that lead wire running through their skin, and they start to notice the pressure and they start to pick at it. And I've heard of cases where they'll pick through their skin to get at the wires and then you run into other problems because once you open the skin, you get infections and so on. So I've heard of cases where they've actually had to take it out because of that. They just couldn't do it anymore. So That seems to be the deep brain stimulation. Now, where does behavior therapy fit in? This is why we're here today, so listen about behavior therapy for Tourette's. Where does behavior therapy for Tourette's fit in? Well, one of the interesting features of this disorder, and actually a lot of other movement disorders, that I don't think is ever fully appreciated by the medical community, frankly, is this. That the symptoms of Tourette's are heavily, and the key is predictably influenced by their environment, okay, by their surroundings. So how many of you actually have ever worked with a kid with Tourette's? Okay, so think about this for a little bit. Can you point to situations where you know that child's tics will get worse? I mean, you just know it. Like, he goes into this, the tics are going to flare up. Or vice versa. If he goes into another situation, his tics are pretty low. You know, most people with Tourette's will answer yes. If they worked with enough kids with Tourette's, they'll say, yeah, I know that. I've seen that before. When I do this talk to physicians, most of the time I talk to psychiatrists and neurologists because that's who treats most of these kids at this point. What I'll do if I have 100 psychiatrists who are watching it, I'll say, how many of you have noticed that your patient's tics increase in some situations and decrease in others, and it's predictable? You know exactly when it's going to happen. 100 hands go up. And then I ask the next question. How many of you use that information clinically to help your patient? And 100 hands go down. Okay, that's an important key. We know from our own clinical observations, even the most skeptical Tourette's person knows that when your patient is in certain environmental situations, certain contextual situations, tics will be increased. Certain contextual situations, tics will be decreased. And it's predictable, it's lawful. Yet that's not used to treat the patient. It could be, and that's what behavior therapy brings to this. So that's a key piece. That's kind of the basis for why we do behavior therapy for Tourette's. I want to talk at this point a little bit about the behavioral model for Tourette's. Tourette's is a genetic disorder. It's not a one gene kind of disorder. You're not going to have the gene for Tourette syndrome. That pretty much everybody agrees that that's not going to happen. It's going to be polygenomic. But we do know it's inherited. It runs down family lines. It may not be direct. You might have great-grandpa so-and-so had Tourette's or had funny movements, and then your son has it. It could be something like that. But the family studies are pretty clear that Tourette's runs in families. But what does that mean in terms of biologically? Well, the theory for Tourette's is this. Think of, this is where tics come from. When you get ready to move, your brain, your motor cortex, is preparing a lot of different types of movements. When I'm standing up here talking, I'm doing a certain sequence of movements, but I could be doing a lot of other things. Instead of going like this, I could go like this. Instead of talking, I could be looking around, or I could be jumping, I could be standing, I could be bending my knees, I could be doing a whole host of movements at any one time. My brain is getting me ready for everything I could be doing at this point. It's like selecting a lot of different motor patterns, and it's getting ready to do a lot of different things. Okay? It sends those signals down deeper into the brain. Now keep in mind, the motor patterns that are stored aren't full movements. When we get ready to move, we're not there's not a cell in my brain that allows me to do jumping jacks. There's not the jumping jack cell. That's not the motor pattern that's stored. We store motor patterns in very small little units, all right, that get coordinated into big gross movements later on. So all these little bits of movement are stored up here. When we get ready to do something, a lot of signals get prepared and get sent down deep into the brain for processing, where eventually they'll get selected out. The ones that are appropriate will be coordinated into a full movement, and then we'll actually execute a movement. Right. So all these, think of your brain being bombarded with these little signals to move. Those signals all go down into a structure called the basal ganglia. Now this is obviously a simplification, but they all go down into this structure called the basal ganglia. The basal ganglia's job, at least one of them, is to select certain movements and inhibit others. Okay, so all these signals are coming down. The basal ganglia acts like a braking system or a filter. It allows certain movements to go through and keeps other movements from going through. All right? That's roughly its job. The movements that get through, go into the thalamus, get coordinated with sensory experiences, and then get executed as movement. They go back up into the cortex and get executed as movement. The ones that don't get stuck. They just kind of like that. They just, they're done. They get filtered out at the basal ganglia. Now, the other interesting piece of the basal ganglia, one of the other interesting parts that it deals with, is reward processing and contextual interpretation. So it also has a lot of feedback processes from reward processing centers. So that's how it knows, so to speak, which movements are appropriate for a given situation and which aren't. So the signals come down, the basal ganglia looks and says, okay, what's my situation? Given the history in this situation, what movement is appropriate? Which bits of these movements should I let through? Looks to the reward processing center, says, okay, what does my history tell me? Okay, let it through. All right, and then out it goes. That's a normal brain, roughly. In the basal ganglia, in Tourette's, it's smaller. The volume of the basal ganglia is smaller in people with Tourette's. They don't have as much of that inhibitory capacity. Their brakes are broken. Think of it that way. They can't inhibit the way most of us would. Now, this isn't an intentional inhibition. Well, there's a different process for that. This is just base motor inhibition, so keep that in mind. That explains, if you think about it, why some tics are actually very appropriate for a situation, even if they're inappropriate. So if you see somebody with a certain characteristic, you might think that characteristic, but you would never say it. Okay? You don't think to inhibit it, it wouldn't come out. A person with Tourette's sees that characteristic and out it comes because they don't have the braking system in place that the rest of us would have. Think of it that way. Another example, if I go like this, some of you might feel the urge to yawn. Okay? Very common thing. We have kind of mimicry neurons, mirror neurons that make us want to echo behavior that people do. Most of us won't yawn in that point because we know that socially that would be rude. Of course, 2 hours from now you'll all be yawning and that's completely fine. But we wouldn't do that, and our basal ganglia gets that signal, do this, and it gets shut off. It's not appropriate for the context, so it gets shut off. People with Tourette's do the exact same thing. If I do a tic like this, even if a person with Tourette's doesn't have this, a lot of times they'll start doing this. Not permanently, but they'll just do it one-off. Or if you want to get their tics going, do the tic, like mimic the tic that they have, and it'll fire off almost immediately. Or at least they'll say they have the urge to do it. And so it tells you kind of the same thing. The imitation isn't abnormal, but the ability to inhibit is in that kind of situation. In any case, that's what leads to the tics. They're little bits of movement that slip through the braking system of the brain. Think of it that way. And then they get stuck in sort of a pattern. They get stuck in a loop. Now, the interesting part about Tourette's is that, well, in fact, about all brains, is we actually have an emergency brake in our brain. And it's from the prefrontal cortex down into the basal ganglia. There are pathways that go from the prefrontal cortex down into the basal ganglia. Think of those as emergency brakes in our brain. And that's like if you're getting ready to tell off your boss who you just can't stand, and he walks in the room and you're going to do it, and you ready to, you know what I think, sir? I think you are the most wonderful human being I have ever met. That's your emergency brake kicking in. It's like you shouldn't do it, you want to pull back, you want to stop. And that part of the brain is actually intact in people with Tourette syndrome. Okay? They have that capacity, once they notice something's happening, to hold it, okay? To intentionally inhibit. That part of the brain is intact, if not intact, even stronger in people with Tourette's. There's some evidence from neuroimaging studies that part of the brain, that pathway, is actually stronger in people with Tourette's than adults, or than people without Tourette's. And some of the theory is that it comes from practicing the inhibition of tics that builds up that pathway in the brain. So that's what we're working with biologically. Now, there's been a lot of research trying to look at understanding the biology of Tourette's. But I'm afraid that by focusing only on the biology, we might be missing the boat. And I don't just say that for Tourette's. I think I might say that for almost all psychiatric disorders that we have. We're spending a lot of time focusing on biology, and I think we're missing context. The brain, the physiology, puts out the tics. The tics emerge from the disrupted brain physiology. But that's not where it ends. That's actually just where it starts. I mean, remember what the function of the brain is. The purpose of the brain is to adapt. That's why it exists. The brain adapted to be adaptable. And so it's built to react to the environment. It's built to change in reaction to the environment. That's its job. And so to study it as a static organ doesn't make any sense. It's not that. So to understand adaptability of the brain, we have to understand the context that the behavior and that brain are functioning in. So when the tics get out into the environment, they're going to have an effect on that environment. And by environment, I'm speaking in the most radical sense. I mean all of the environment, the internal experience, the internal environment that the person has inside their skin, and the external environment that the person has, the environment outside their skin. So when a tic occurs, what changes in the environment? Well, social reactions happen. Okay? That can change the future frequency of the tics. The person doesn't have that urge anymore. That changes right after a tic. So the tic will interact with that environment. That environment will change as a function of tics. And as a result, that environment will come to control the tics in a predictable way. So you start getting this synergy. The environment starts to affect the tics start to affect the environment. Now, of course, that's all happening through changes in the brain that lead to the tics in the first place, because that's what the brain does. It adapts to environmental circumstances. Now, traditionally, understanding the relationships between environment and behavior, those environmental behavior relationships, that's been the traditional domain of behavioral psychology, of behavior analysis. We used to study that a lot, whole subfields dedicated to that, and there are still a few of us that are left. It feels like it's getting smaller and smaller every year. But really, the purpose being to study the environment-behavior relationships in a lawful, predictable way. Principles of reinforcement, punishment, so on and so forth. That's our traditional domain. If we can understand that, if we can understand how when environmental change A happens, it affects the behavior in a predictable way, and environmental change B happens, it affects the behavior in a predictable way, then we can start to understand the environment-behavior context. The traditional domain of psychiatry and neuroscience has been studying the brain and the physiology. I worry sometimes that psychology is trying to become too much of psychiatry and neuroscience and kind of forgetting what psychology was supposed to have been about. But that's just my pessimistic view. Why should we look for these environment-tic relationships? Simple. If we can understand the environment, how these environmental antecedents and consequences impact tics, if we can understand that in the most predictable, lawful fashion, then the environment can be modified in a targeted way to promote tic reduction. Understand how the environment affects tics, change the environment. You can bring down tics. Simple concept of behavior therapy. What are the environment-tic relationships that maintain tics? Well, we classify these environmental variables into antecedents and consequences. Antecedents are events that come before tics that make tics more or less likely to happen. Consequences are events that come after tics that make tics more or less likely to happen in similar circumstances in the future. Places, situations, other people, activities, internal experiences, all these factors can make tics better or worse depending on the person. Consequences, positive reinforcement and negative reinforcement. So reactions to tics that make tics more likely to happen in certain circumstances in the future. Negative reinforcement, escaping from aversive experiences as a function of the tics, can make tics more or less more likely to happen usually. Let's talk about some of the antecedent events that impact tics. There was a study done by Raul Silva, who's a psychiatrist, who was really just trying to describe the experiences of people with Tourette syndrome. I actually think he did this was probably one of the most important studies at its time for Tourette syndrome, although I don't think he realized it was as important as I think it is now. And you'll probably laugh when you hear me describe the study because it doesn't sound very important methodologically, but you'll see in a little bit. Silva interviewed or had people with Tourette's complete a checklist of He had a whole host of different environmental circumstances, and he asked the people who were completing it with Tourette's, said, tell us if this situation makes your tics better, worse, or doesn't change your tics at all. Okay. He found that being upset or anxious made many people's tics worse. For a smaller subset, it actually made their tics better, so getting upset or anxious decreased their tics. And for a third group, it didn't really change their tics at all. He found that watching television made many people's tics better. Some people's tics worse, and some people's tics weren't changed at all. He found that being alone made some people worse, some people better, and some people it didn't impact their tics at all. He found that being around other people made some people better, some people worse, and others it didn't affect their tics at all. Now you might be sitting there thinking, is he crazy? Why on earth does he think this is so groundbreaking? If you think that, you're missing the boat. Two things embedded into those statements. One is that people can say, when I do this, my tics get worse. That's huge because it tells us that there's a predictability to the environment for these people. The second part of it, in 95 when that came out, nobody had thought to quantify that at all. Nobody had thought to empirically claim that. The second part is that everybody's different. And that's the other key feature, is that there isn't a one-size-fits-all to environment-behavior relationships for people with Tourette's. And you wouldn't expect it to be from a behavioral standpoint. But everybody's environment will affect them in predictable but different ways. And so to really develop a useful treatment, we have to have that individualized approach to understanding. Stressful life events, hearing others cough, talking about tics. We did a study that showed simply talking about tics, not asking them to show you their tics, but just discussing tics, like what it's like to live with them and so on, actually reliably increases tic frequency, as opposed to conversation that's not related to tics. So that tells you something. When you're diagnosing kids with Tourette's, don't base your diagnosis on when you're asking them about their Tourette's. Base their severity diagnosis on when you're not asking them about Tourette's, because that's going to be your more conservative approach. Interestingly, that only affected vocal tics. It didn't affect motor tics, which was strange. Consequence events that impact tics. What are the different reactions to tics, or the things that happen or change in the environment after tics that make tics more or less frequent? Well, let's talk about what can make tics more frequent. Social reactions. There was a study done by a couple psychologists, Watson and Sterling, not John B. Watson. He was long dead by the time this study was done. But Watson and Sterling did a study looking at social reactions to tics. And what this study did, it basically reported on a study of it was a single case experimental design of a young girl who had one of her tics was a chronic cough, constant kind of thing. And the parents were going crazy by this. They couldn't stand it anymore. And essentially what Watson and Sterling did, they went in and they did a functional assessment. And they said, okay, what seems to be happening when this child does this? And they watched the child and the parents at the dinner table. And what they found was that almost throughout the whole meals, all of the meals when they were doing the observations, they found that when the child would tic, the parents would react. Stop it. Quit it. I can't stand it. Be quiet. Those kinds of things. Okay. When the child was quiet, which wasn't very often, they didn't really react at all. So Watson and Sterling flipped the contingency on its head. And what they did was they told the parents simple instruction. When your child's ticking, don't react. When she's quiet for at least 15 seconds, then say something to her. Talk to her about her day. Those kinds. Pay attention to her after 15 seconds of silence. And they did this contingency, and within days, her tics plummeted from almost near constant to a couple. Now, you wouldn't expect her tics to go away completely. That's behavior therapy, behavioral interventions aren't a cure for Tourette's. But what behavioral interventions can do is scrape off the effects of the environment. It can bring the frequency and the intensity back down to what the biology should be producing, rather than allowing it to flourish and bloom into a bigger problem than it needs to be. But Watson and Sterling really demonstrated with this study that social reactions to tics make a difference. You can actually reinforce tics and make tics worse than they need to be through social reactions contingent on the tics. What does this look like in real life? One is the example I just gave. Parental attention or comfort that parents give children after they do a big bout of tics can actually make the tics worse than they need to be, help maintain the tics. Think of it like this. If you have a child and your child's tic is a really violent head jerking thing, like just brutal head jerking tic, and your child starts to do it and he starts to cry and rub his neck and he just, it's really painful for him. If you are a parent with any kind of soul, if you have any sort of love in your heart for your child or just for humanity, your first reaction should be your natural gut instinct should be to run up to your child to make sure they're okay, rub their neck, hold their neck, tell them it's going to be okay, that kind of thing. If you have children and you don't have that instinct, you shouldn't have children. You should give them away. However, that is probably not the right reaction to have. It's the natural reaction, but it's probably the wrong reaction for this situation. Because what does that do? I give this example when I talk to parents of kids with Tourette's. And I get usually much more detailed than that, and I see a lot of head shaking, and then I deliver the punchline. Because they've all been there. They know exactly what I'm talking about wanting to comfort your child when these tics get really bad. And when they comfort, it's like heaping on the stuff. The kid has a huge burst of tics, and then they start rubbing the child's back. They'll hold the child's neck, and hugs and kisses, and it's going to be okay. A lot of one-on-one, great quality time. And the parents are all like, yep, that's what I do. And then I stop and I say, now, how many of you do that level of attention when they're quiet and not ticking? And then the heads kind of go down because they know they don't. And that's natural too, because they're normal parents who are harried and they're busy and they've got things to do and they've got mouths to feed and work to take care of and houses to clean. They respond to problems, right? But we've got to teach these parents that natural response that you have as a parent for your child might actually could make their symptoms worse than they need to be. So we need to teach them how to comfort correctly. We need to teach them to attend to the child with that kind of love and affection when the tics are lower, not when they're higher. We need to teach them to respond differently. Peer attention. A child who doesn't have many friends, maybe he's got ADHD and he's really kind of irritating to everybody, and the only time he does get any attention is when he tics and can make the teacher, feel silly, and the kids love that, so they laugh when he does something that offends the teacher. That's some attention that could help maintain the tics. Does it cause the tics? No, but it can make them worse than they need to be. Escape from an aversive situation. Imagine being a third grader and your tics are just starting to peak, and your teacher decides, and you don't have a good ability to read. You've got a reading disability as well. And your third grade teacher decides it's a great idea in your reading class to stand up. Each of you stand up in class and read a paragraph out loud as you work through a book. So your teacher has you stand up and you have a pretty loud vocal tic. It gets a little worse when you get anxious. So your teacher says, stand up and read. I went to the store and pretty soon you're uncomfortable as the reader. The teacher's uncomfortable because she doesn't like seeing a third grader struggle so much socially. And all the kids are uncomfortable because you're loud and they're embarrassed for you. So what does the teacher do? The teacher says, why don't you just put your book down, leave the classroom, go to the nurse's office and just get your tics out and get yourself together. And then when you feel like you're okay, you can come back, right? That's what we tell teachers to do, actually. But what's the message that's sent there when we say that? The important message is don't read. Put your book down. You don't have to read if you tic a lot. And you struggle with reading, and reading that way that the teacher was doing it is embarrassing for you, and tics allow you to get out of that situation. Now, is the child sitting there thinking that intentionally? No. But the child doesn't have to be aware of the contingency for the contingency to take effect. But that's the very real nature of what's happening for a lot of these kids. You can look in manuals and self-help books on how to treat kids with Tourette's, and that's step number one. If a child's ticking a lot in classroom, give them a safe place to tic. And that's okay, as long as the safe place to tic involves them still having to do the work. And that's the concern, is that sometimes that doesn't happen. So allowing a child to escape from aversive situations because of the tics can turn into a pretty nasty reinforcement cycle. Kid starts to do homework, starts ticking a lot, and the parents say, okay, just don't do homework. You don't have to do homework now. Just don't do it. That happens. child has to go to bed, he starts ticking a lot, the parents say, okay, you can stay up. That's fine. Those happen all the time. And it's, again, could make the tics worse than they need to be. Another consequence event that can make tics more frequent than they need to be is the reduction of the premonitory urge as a result of the tic. So that unpleasant feeling builds up, the tic happens, and there's a brief period of relief. The tic builds up, the feeling builds up again, the tic happens, there's a brief period of relief. That very fixed ratio 1 schedule that people get on, negative reinforcement cycle, is very powerful, and it's right there for them. Now, just like tics can be made more frequent by environmental circumstances, tics can also be made less frequent by environmental circumstances. Remember, at the beginning I said tics can be suppressed voluntarily for at least a short period of time. Suppression is a behavior. So you can reinforce behavior, and suppression can be reinforced. How does it get reinforced? Now, we've done a whole series of studies, probably about 7 or 8 studies now, really testing whether reinforcement can be used to increase suppression, and without a doubt it can be. So in the lab we know this is not crazy. In fact, we've shown that we can actually create stimulus control over tics. So we had a study where we put children in a room and reinforced them. Every 10 seconds they went without a tic, we gave them a token. They got very good at suppressing their tics. And in another study, we then said, okay, when a purple light's on our token machine, and you suppress, then you get tokens. When no lights are on, you don't get tokens. We had them practice that 4 days in a row. On the 5th day, we brought them into the lab, and we didn't tell them anything. We didn't give them any instructions. We didn't give them any tokens. We turned purple lights on and off our machine. And very quickly, what we found is when the purple lights were on, the kids' tics started to drop. When the purple light was off, the kids' tics started to increase. So we had actually showed that through reinforcing suppression, you can actually come to exert environmental control over the tic suppression. It's actually a very reliable kind of finding. In any case, how does that look in real life? What are the reinforcers for suppressing tics in real life? Well, one is avoiding being teased. You know, the better you get at suppression, the less teasing you get. The less teasing you get, maybe the better you get at suppression. Being able to participate in social activities or sports, the better you learn to suppress, the more activities you get engaged in without embarrassment. Okay. One of the things that's interesting in people with Tourette's that you'll see is a lot of times children with Tourette's, their parents will come in and they'll say, you know, my son doesn't really tic at school. The teachers don't even recognize it. But boy, they come home and it explodes. The assumption there from parents' perspective is that they're holding their tics in all day, and then they have to get them out at school, or get them out when they come home. Another way to look at it is that all the reinforcers for not having tics are at school. That's where the reinforcers for suppression are. When the child comes home, the reinforcers for suppression aren't there anymore. This child isn't getting teased if they tic. You know, the parents wouldn't do that. Most parents wouldn't. And so, you know, the contingencies shift from one environment to another, which might be an explanation for why the symptoms vary so much from situation to situation. Okay. I want to talk a little bit more detail about this negative reinforcement hypothesis, just so we understand what this is. Remember, because this is a key piece to the understanding Tourette's, I think. You know, all those environmental circumstances are influencing tic. You know, reactions to tics can influence tics, different antecedents can influence tics, but that's very different for everybody. This seems to be the one contingency that's pretty much in place for everybody with Tourette's. Right? This is the one maintaining factor from a behavioral standpoint that's true for almost everybody. This urge is there, it builds up, the person tics, and then this experienced as relief. Now we call that negative reinforcement. Right? And it's also a very tough to get rid of negative reinforcement contingency. It's on a fixed ratio 1 schedule, meaning every time the tic happens, the reinforcement is delivered, and it's immediate. So you've got the hardest contingency on earth to deal with. A reinforcement contingency delivered every time, continuously, and immediately. That's a very strong contingency. And we'll talk about how we have to get rid of that in a little bit. So the behavioral treatments are based on the following principles. Basically, that was the theoretical background of Tourette's from a behavioral perspective. But when we're talking about treatment development, we can say that the person's internal and external environment impact Tourette symptoms. We can say that the effects of these factors are unique to the individual, so everybody's a little bit different. And if we're going to develop a useful treatment, then we have to address both the external and the internal contingencies. The question is, how do we do that? Well, let's talk about how we deal with the external contingencies, those social reactions, the different environmental or contextual antecedents that predictably influence tics. We use a process that most of you are probably familiar with called functional assessment and, by extension, function-based interventions. What we try to do is identify situations in the child's environment that are associated with exacerbations of tics. And I say it that way because I don't want people to think that what we're looking for are any time the tic happens, what were the antecedents and consequences. I'm not looking at that. What I'm looking for are broader factors saying when your tics are getting worse during the day or getting better during the day, what's happening in your environment? And what we're looking for are commonalities, common environmental occurrences or contextual occurrences that are happening with exacerbations of tics, common reactions that happen as tics get worse. And what we're trying to do is find those kinds of patterns. And the reason we don't look at every time the symptom occurs is because tics occur throughout the day, just in general. They're going to happen if the child's sitting in a room by themselves, the tics will happen. Because the baseline neurology is there. What we're looking for are factors associated with exacerbations. So we do this through an interview with the parents, and we'll talk more in more detail in the afternoon about how to actually do this, but I might sit with the parent and say, okay, tell me about when your son's tics are generally worse than usual. All right, can we talk about that? Think about your son's tics and tell me when they're worse than usual. And Billy's mom says, oh, here it is. This is like the worst time of day, right after school when he gets home. And I'll say something like, well, tell me about that. Tell me about a typical day for you. Well, Billy comes home from school. He's like 9 years old, and he's always stressed out. He's anxious right after he gets home from school. I'm a single mom. I get home a little bit before he does from work, and I'd picked his sister up from daycare, and she's downstairs, and he gets home and he goes to the den where his sister's watching television. And he starts ticking really loudly. He really kind of has a lot of vocal tics and makes a lot of noise. This drives his sister crazy because she can't hear the TV. She's really upset with him. And then she'll start yelling at him and teasing him, and it really makes him upset because he feels bad. He hates having these tics. He gets so embarrassed by it. And pretty soon they'll start fighting, and ultimately she'll keep pushing and pushing and pushing until he starts crying. When I hear him cry and I get really upset because it's probably my fault he has these tics. My dad had Tourette's and it's probably my fault. It's my genes that led to this. And so I go downstairs and I see this poor kid. He's crying, he's sobbing. He tells me he doesn't want to live anymore because he can't stand the tics. And his sister's just kind of laughing while she's watching TV, and I get really angry with her, and I send her out of the room, and I sit down with Billy and I give him a hug and a kiss, and I tell him it's going to be okay. And after a few minutes when he starts calming down, I say, why don't you just watch TV, get yourself together, get your tics down, and when everything calms down, we'll have a good rest of the day. Okay? And then I go back up to make dinner. That is my life in a nutshell. Every day after school, that's what's happening. That's what the mom tells us. As we're listening to this, what we're trying to do is stay out of the emotion of the thing and listen for the antecedents and the consequences. We're trying to say, okay, what factors are associated before the tics happen with exacerbations, and what factors are associated after the tics that make the tics potentially worse. Now, we can't say for sure whether any of these factors are making the tics better or worse. We just have to have good guesses. But we say, okay, what are some antecedents? And there are a lot of antecedents in here. Well, one is that Billy's tics get worse when he's anxious. We ask Mom about that. Does when he's stressed or anxious, do his tics otherwise get worse? She goes, yeah. So we figure that out. When Billy's in the den, his tics happen a little more. We might ask Mom, so does he tic a lot when he's outside after school? And Mom says, no, he doesn't really. He goes outside. He has tics, but they're not really bad after school when he goes outside. So we find that maybe being in this den, secluded den area is a trigger for the tics. We look at consequences. What happens right after Billy tics that could make his tics worse than they need to be? Well, his sister, who he probably doesn't like too much at that point, gets sent out of the room. That could be a potential reinforcer. He gets mom's love and attention at a dose that he doesn't normally get it. That could be a potential reinforcer. And he gets the TV to himself. Sister had been watching Hannah Montana, and that gets flipped off, and he gets to put SpongeBob on, and he's happier. All right? So a whole bunch of things change when he starts having a big burst of tics. Now, do we know for sure that any one of these factors made his tics worse? No, but they could be. And so what we do is take that assessment and we start coming up with strategies that the family can use to bring about potential reductions in tics. So for example, if we think about anxiety as being a tic exacerbator, what we do is teach him relaxation strategies appropriate for his age level that would allow him to relax in those situations where he's stressed or anxious. Relaxation training as a standalone treatment for Tourette's doesn't work. We know that. But used as a targeted intervention in particular situations where stress is present might be able to be helpful. In the den after school, what we would do is probably change the setting. We would say, you know what, on most days of the week, let's change up how this is done. No more TV right after school in the den. Let's send him outside. Let's give him something active to do instead of just sitting when he gets home from school. Consequences. Instead of having the teasing sister sent to the room, what we might do is have the sister stay in the room, bring her into treatment sessions with Billy, and start to work to bring her on as an ally to her brother rather than someone who's going to oppose her brother. Now, she's young, so it'll take some work, but we can do those kinds of things in therapy. Instead of mom comforting Billy the way she is, contingent on a group of tics, we'll try to change the way she comforts. We'll teach her to comfort smartly. In other words, don't pay much attention to the tics when they happen. If he's going to injure himself, prevent him from injuring himself. But really, let's not pay a lot of attention to the tics in the moment. When he's at a low tic period, then you can talk to him about it and see how he's doing, and that's when you provide the comfort and the attention. When Billy gets the TV to himself, we do away with that. We say, let's limit the amount of TV, let's make this our homework practice time for therapy, so on and so forth. Okay. Now, what about this contingency, the internal environment? Well, the best way, or an effective way to get rid of a negative reinforcement contingency is to do extinction, operant extinction of a negative reinforcement contingency. Most people, this is probably a fairly friendly behavior therapy crowd, so you might understand this, but a lot of times everybody thinks negative reinforcement means punishment, so this whole throws them completely. If you're really going to do extinction of a negative reinforcement contingency, what you have to do is have the urge happen, the tic occurs, and then you have to block relief of the urge. That's true extinction of a negative reinforcement contingency. I have no idea how to do that. If anybody has an idea how to do that, allowing the person to tic but not getting rid of the urge, please let me know, because we could be very successful, I think, if we could come up with that. What we have to do is, instead of focusing on the back end, we have to focus on the front end. We have to let the urge happen, block the tic from occurring, and then hope that the urge goes away, okay, on its own, like an OCD model. Now, fortunately, that does seem to happen. Okay? Most people with Tourette's don't believe it will happen when you first present this to them. Then you ask them, how long have you tried before doing the tic? I don't know, a couple minutes? What if it goes away in 5 minutes rather than 2? I don't know, I've never waited 5 minutes because it's so uncomfortable. What if it goes away in 4 minutes rather than 2? I don't know, I've never waited that long. So they don't normally think of it this way. The habituation to the premonitory urge, though, in most cases does happen. And clinically, what I can tell you is that it gets faster and faster and faster the more they practice it. The first time it might take a few minutes, if not an hour, hour and a half. The second time, it gets faster. And within, I'm talking a week, usually what happens is the urge shows up, the person blocks the tic, and then the urge fades very, very quickly, within seconds, usually. So it can happen very quickly. I had a patient once that was seen in our clinic. It was an adult male with Tourette's, very bad neck jerking tic, violent head jerking tic that had caused a lot of damage physiologically. He'd lost feeling in his hands because he cracked some vertebrae in his neck because of the C4 and C5 vertebrae had cracked in his neck because of a tic. And he had had 2 spinal fusion surgeries and had seriously impacted his career in a lot of ways. He was considering deep brain stimulation. He had tried all the medications and so on. He had heard about our clinic on the internet, so he went down. And the way I run my clinic at Milwaukee, I have a specialty clinic just on Tourette's and Trichotillomania and other repetitive behavior problems. And my students staff it. We meet on Wednesday nights and we run it. We collect data the whole time we're doing it, and so on and so forth. And one of my students was seeing his first patient ever, his first live patient. He was the lead therapist now, and I was behind the mirror watching him. And this is the guy who came in to see him. And he starts talking about how his physicians have told him that if he keeps doing this tic, he'll be paralyzed, and so on and so forth. And he was very, he was accurate about that. And I'm watching my poor student listen to this guy, do the interview. And my student's turning just different shades of pale because he's like getting, this is way over my head, he's thinking. So I run around from the mirror and I sit down and talk to this guy. And we ask him, it's like, how often are you doing this tic? And he said, I'm doing it, and it's a violent head-jerking thing for it. I can't do it because it hurts to actually do. I've done it once and I about knocked myself out, and it was that violent. And he said he was doing it about 80 times a day. And I honestly can't imagine it, because when he would do it, you'd hear snapping and popping and cracking, audibly sitting next to you. And otherwise, very highly educated, no other comorbid problems. He had Tourette's, just pure Tourette's. And he said, I'm doing it about 80 times a day. And I wanted to explain to him what we were going to do in treatment and give him a week to think about it, because I wanted him to know, wanted him to think about whether he could actually do the intervention or not without any risk to himself. And so I explained to him, I said, what we're going to do in intervention, and I'll explain it to you today, and I want you to think about it for a week and then come back and tell me if you think it's something you want to do. What we're going to do is to teach you to be aware of the urge to do this neck tic. I said, I bet you have a feeling in your neck that tells you this is coming. And he goes, oh yeah, it runs right up the back of my neck. I said, we're going to teach you to be aware of that, and then we're going to give you something to do that can stop your tics for you. And what we'll ask you to do is to do that tic stopping thing for a while until that feeling goes away. And we'll have you practice that every time you feel the urge to tic. And usually what happens is, as you keep practicing, you might have to wait a long time the first time, but if you keep practicing, that urge will start to go away faster and faster and faster and faster and faster. And the more you practice, the faster it'll go away. And he's like, that urge goes away? I said, well, not for everybody, but for a lot of people it does. He goes, wow, I never thought about that. Okay, well, I'll think about it for the week and I'll let you know. So he comes back the next week, and I'm behind the mirror again, and my student's interviewing him. And my student said, so how'd the week go? And the guy said, it went great. It was wonderful. And my student said, well, really? How many times did you do the neck jerking tic? Because we had him self-monitor. I did it 5 times this week. And my student said, 5 times a day you did it? Like, that's really good. He goes, no, not 5 times a day, 5 times. And all 5 times it was like this. And so I run around the room, go in and find out what's going on here, because we didn't do anything. And so I asked him, I said, so how did this happen? I don't get it. He said, well, remember, this is a highly educated man. He said, well, you talked about that urge going away. I never thought about that it could go away before. I've tried a little bit, and it lasted a few minutes, and I couldn't take it, so I let it go. I let the tic fly. He said, but when you said that if I waited long enough, it would go away, I decided to try it on the way home. I wanted to see what would happen. So he said, I got in my car, and as soon as I walked out of your office, that urge popped up in the back of my neck. So when it showed up, I just kind of tensed my neck muscles and held my neck tight so it wouldn't go. And I went out to my car, and I drove home for the hour drive home. And then I went out to the garden with my wife, and I started talking with her, and we were doing some gardening, and it was still there. Like, it lasted an hour and a half. But then I noticed as I was gardening that it wasn't happening anymore. It was gone. And then the next time it popped up, I did it again. And now he said when it happened, I just kept doing that all week. And now when the urge pops up, it's just like a very fleeting, quick, it's there and it's gone. And sometimes I don't pay attention to it, so it comes out like this, but that's it. And that was 3 years ago. The guy still is pretty much that way, like 3 years later now. And we didn't do anything. Now we did stuff with other tics that he had, but for that tic, we didn't have to do anything else. because he had figured out what we were going to teach him anyway. He had started doing what we were going to teach him anyway. He understood the principle on which this was based, and he was able to develop his own treatment. And that, when I saw that case for me, that really kind of solidified what we had thought theoretically was happening, which is that this urge, the important part of this treatment is urge habituation, getting used to the urge and letting the urge fade away quicker and quicker and quicker. And I've heard this in many cases when I've now thought to ask. How do we do that? How do we get people to recognize their urge to tic and then give them something to do to prevent the tic? Well, we do something called habit reversal, which is actually a really old treatment. Habit reversal was developed in 1970, well, it was probably developed in 72, but it was first written about in 73 by a psychologist named Nathan Azrin. How many of you have heard of Azrin? That's good. Sometimes I do psychology crowds, and how many of you have heard of Azrin and nobody's hand goes up? That to me, that's kind of sad, considering you think about all the behavior therapy tools that he helped develop. But he developed this in 1973, working in Illinois, actually. He was actually working at a home for the developmentally disabled, a group state hospital for the developmentally disabled. And he developed this self-help kind of treatment for typically developing populations based on some of that work. Habit reversal training does a couple things. One, we think it forces habituation to the premonitory urge. And second, we think it probably sends alternative signals through the basal ganglia, so it sort of floods the basal ganglia and disrupts the habitual motor pattern that is the tic. What is habit reversal? As I said, it's an older treatment. It started in 73. It's used to treat tics along with a lot of other things. It's the basis for treatment of trichotillomania. It's the basis for chronic skin picking treatment. It's the basis for behavior therapies for stuttering. It's the basis for a lot of body-focused repetitive behavior treatment. It has three primary components that we'll talk about in much more detail later on in the afternoon: awareness training, competing response training, and social support. Awareness training is essentially teaching the person to become more aware of their tics and teaching them to become more aware of their urges to tic. A competing response training is we teach the person to do a behavior that physically prevents the tic from happening whenever they notice the tic is happening or is about to happen. We teach them to do the competing response for a minute or until the urge goes away, whichever is longer, at every time they notice a tic or the urge to tic. And then we have social support, which is there to help remind the child to use the competing response exercise or to praise the child if they do use the competing response exercise correctly.